Hello and welcome to our session on Datademic's Data-decision-behaviour, a consolidated approach. My name is Claudia Habel. I'm in charge of international affairs at the Austrian Public Health Institute, GmbH, and I'm part of the Population Health Infrastructure project, PHIRI. Besides our other tasks, like organizing bi-weekly rapid exchange forums of national experts, aiding incompetent authorities in managing the pandemic, PHIRI is also working in tackling the current infodemic. We held, partly in cooperation with WHO, already 2 workshops on infodemic this summer. But besides tackling myths and fake information, we also realized that with the ever-growing amount of data and information spread, it gets more difficult to differ between actual and wrong information, also for our decision makers. This is why we decided to have this session workshop, and I'm now very much looking forward to the inputs of our speakers. But first I have also to introduce, or perhaps not, our dear moderator, Josep Figueras. I think I must not introduce you as you are really a so-called, we say, old Gasteiner. You are from the European Observatory. I think most people attending will know you, and I'm really pleased that you again moderate our session. Over to you.
Thank you, Claudia. Thank you very much indeed. As you know, it's an enormous privilege, and I'm not saying that lightly, to work with you guys, because your sessions are always impeccable, and they're in topics that are very, very close to my heart. As you know, that's what we do for a living in the observatory, and we're learning an awful lot from you. I won't like to add too much because you already framed the session perfectly well, and the title itself tells it all. Perhaps adding a couple of comments. I think what fascinates me about this session, about this debate, is we're talking about this axis of data that is contextualized and becomes information, description that is analyzed and becomes evidence, the why, as it were, how that evidence then gets into knowledge, and hopefully the beliefs, and how that knowledge then goes into decision making. There is this axis that we've been worrying about, Claudia, you and I, and many others over the years. And I think you will agree that even those of us working on that, we still have this sense of rationality. It's this sense of, you know, that's the evidence and the decision. Evidence to decision. You have this beautiful arrow from evidence to decision. Why is it so complex? And it is complex, and that's exactly what we've been going to be talking about today. So we're going to be talking about how the data is processed and their issues into information evidence, are issues of validity and quality and relevance of that research. And then we're going to be talking about how is communicated knowledge brokering, both to the decision makers and to the population for behavioral change. But even that doesn't tell us enough. And what we're doing in this session today, understand, is we're looking at the actors. So we see this continuum, but then we forget often, even working in this field, that we have actors. And these actors, today we have them around the table. Each one of them is kind of role-playing, reflecting one of the key actors in this process, have their own cognitive biases. They have tacit knowledge, not always based on evidence. They have values that do influence their decision-making. And I'm not talking about only policymakers. And it's licit and appropriate that policymakers use their values, reflecting the societal values, in making decisions, as long as we'll talk in a minute, I suppose, this is done transparently. So we need to understand the actors involved in this process, what are their values, their tacit knowledge, their cognitive biases, and we need to understand as well the political economy factors, the political and economic context and pressures to the process itself and to the actors themselves. It is something that we need to remind ourselves, particularly now in public health crisis, and there are many public health crises, not only COVID, we need to remind ourselves that evidence, policy and politics becomes one. It's done simultaneously. There's not this nice continuum. So I think that's going to be one of the elements that are particularly important, will be particularly important in this continuum. I will stop here because what we want today is to hear our protagonists. I'll be introducing them one by one as they give their presentations. We start with our keynote, David Nobili Ortiz. He's regional advisor on data, metrics, and analytics at the Division of Country Health Policies and Systems in WHO. And is our ideal keynote, David, not only because of your knowledge first, and because of your understanding of this field, and because also you are in the hot seat supporting our member states in providing the right data in the right timing and so on. So can you give us your perspective on I suppose, on the first part of the continuum, on the data and the evidence side, the complexities, the timeliness, and how do you get this data, this evidence to our policymakers? David, the floor is yours.
Thank you so much, Josep. Good morning, good afternoon, depending on where you are based. So as Josep said, my name is David, and I am the unit head and regional advisor for the Data Metrics and Analytics unit at the World Health Organization, the regional office for Europe based in Copenhagen. First of all, I would like to thank the Austrian National Public Health Institute and Sciensano for inviting the World Health Organization to this session, for giving me the opportunity to share my views on Datademics. I would also like to thank you for allowing me to continue learning from my fellow panelists, Dr. Carr, Dr. De Bruin, Professor Pagel, Minister Pavluch, and from my good colleague, Josep Figueras. As you can see in this slide, you can find my contact information in case you would like to connect or exchange views in regard to data and information systems. Next slide, please. During the next 15 minutes, I will go over 3 topics. First, I will speak about data in the context of the COVID-19 pandemic, in particular, how data has been used to make public health, social, and economic measures. And next, I will talk about some lessons learned. Second, and because this session is called Datademics, I am going to share with you 20 numbers related to the use of data to monitor global progress, support data-driven decisions, and the impact of information and communication technologies on data and information. And finally, I will briefly present a call to action with 3 concrete actions that could help us to collectively change the current situation related to data. Next slide, please. As you know, along with the work of health workers, data have been a key tool to effectively tackle this pandemic. During these unprecedented times, I have had the opportunity to lead response teams on the ground, and I have seen firsthand that data are more urgently needed than ever to inform critical interventions. In particular, to learn about the epidemiological situation, healthcare capacities, including health system functions, public health capacities, and the availability of effective pharmaceutical interventions. Data have been also needed to determine multi-sectoral and non-pharmaceutical measures, such as lockdowns or temporary suspensions of socioeconomic activities. And finally, to monitor the wider effects on population health, because this pandemic and the actions taken to control this virus have an impact on population health beyond the direct morbidity and mortality it has caused. The range of these effects is broad and include, among others, disruption of health services and social, economic, and psychological impacts. Please stay in this slide, and I will let you know when we need to move, please. So now, of course, the next slide, please. Thank you so much. Now, of course, we have learned a lot from this pandemic. In brief, our inability to effectively leverage the volume and different types of data available to us has been a notable shortcoming of the response to data. This is due to several barriers, including lack of health data standards related to the definition, calculation, and format of the data, delays in receiving data, the lack of integration and interoperability between the different data and health information systems, and the deficiency of trained people to manage and use this data. This situation brings home the point that it is imperative for each country to strengthen its data and health information systems in place so that data gaps can be closed. With this, I conclude the first part of my presentation. And with this, I just wanted to highlight the importance of robust data and the current challenges and data gaps that countries are facing, even when there is political commitment at the highest level. And this is critical because a health information system, it's not just about having a lot of data, it is about having good quality data obtained with robust data systems. Next slide, please. Moving to the second part of my presentation, I'm going to share with you 20 numbers related to the use of data to monitor global progress, support data-driven decisions, and the direct impact of information and communication technologies on data and information. The first 8 numbers are related to monitoring global progress and supporting data-driven decisions. As you may know, in September 2015, the 193 United Nations member states agreed on the Sustainable Development Goals to be a blueprint to achieve a better and more sustainable future for all, and are intended to be achieved by the year 2030. The original global SDG framework included 17 interlinked goals, 169 targets, 232 unique indicators, and 57 of these indicators have been identified as health-related SDGs. That is, pertaining to health outcomes, health services, and well-established environmental, occupational, behavioral, and metabolic risks. These 4 numbers represent the highest political commitment, particularly through the SDG 3 regarding good health and well-being to achieve health for all. Next slide, please. Now let's focus on the measurement framework of the SDGs, and let's have a data reality check around this. First, let's share a number related to data timeliness. 2017 represents the most recent year available by goal for the SDG 3. This is the weighted average of the median country by indicator. This means an average time lag of about 4 years in reporting for many health-related indicators. Furthermore, an analysis of all the indicators in the global SDG indicators database reveals that for 5 of the 17 SDGs, in other words, 30% of the SDGs, fewer than half of the 193 countries or areas have internationally comparable data. This lack of country-level data is particularly worrisome for Goal 13 related to climate action, where on average, only about 1 in 6 countries have data available. Country-level data deficits are also significant areas related to sustainable cities and communities, the SDG 11, peace, justice, and strong institutions, Goal 16, sustainable production and consumption, Goal 12, and gender equality, Goal 5. What's more, lockdown measures implemented to control the spread of COVID-19 have hindered data collection efforts for much of 2020, widening gaps in the capacity of countries to report on many of the indicators. Due to the relevance of civil registration and vital statistics, another important number that you need to know is 56, which represents the percentage of countries worldwide that have better registration data that are at least 90% complete. This means that only 138 out of 246 countries and areas have high-quality birth registration data. Finally, we cannot underestimate the cost of collecting data. Since the Global Partnership for Sustainable Development data estimates around 650 million per year is needed to collect SDG data, of which only 250 million is currently funded. I hope that these first numbers help us to appreciate the political commitment of our countries and to understand the current challenges for proper global monitoring progress and data-driven decision-making. Next slide, please. Now, continuing with the second part of this presentation, I would like to focus the remaining 12 numbers that I plan to share on the impact of the information and communication technologies on the current data situation, and moreover, on the population in general. The way we currently communicate, share, receive, use, and search for both general and health-specific information has been deeply altered in the last 20 years. At present, 51% of the world's population use the internet. The global expansion of social media covers around 54% of the world's population, and 90% of the population has access to mobile broadband network. Furthermore, 72% of Europeans have used the internet to search for health-related information. Next slide, please. Regarding these 72% of Europeans that have used the internet to search for health-related information, it's important to know that 8 out of 10 of the health-related consultations, in other words, 80%, start through search engines like Google, Yahoo, or Bing. Furthermore, we also know that an estimated 7% of Google's daily searches are health-related. These numbers clearly are pointing us to where the user goes when there is a need for health-related information, which brings us to the next question: how much information is available out there? Just a simple query on Google about COVID-19 will give us around 4 billion with B results, putting the users in a difficult position to determine what information to consume for any kind of the self-decision making. In this particular example, referring to Google and COVID-19, it's true that big tech companies and social media platforms are doing their best to offer reliable information to users. As an example, WHO has collaborated with Twitter, Facebook, Instagram, LinkedIn, Snapchat, TikTok, Pinterest, YouTube, and others to direct people to WHO or national health institutions when searching for coronavirus information. This is a big step in the fight against misinformation. We hope that this collaboration has been extended to other health-related topics to ensure that there is more reliable information when searching for this kind of information. Because currently, the presence of reliable information for national authorities when looking for health-related topics is still scarce. And this connects us with the last number in this slide, 7%, which refers to a study that I conducted in the 18 Spanish-speaking Latin American and Caribbean countries in 2016, which showed that in the top 10 results on Google, there was a 7% possibility of finding information on the 10 leading causes of death in a country from national health authorities. Next slide, please. To conclude with the second part of this presentation, and in connection with the incredible amount of information that is available, I would like to share with you some numbers related to the proportion of posts identified as misinformation during the current and previous health emergencies. As an example, 4% of posts were identified as misinformation in the case of the H1N1 health emergency, 24% in the case of Zika on YouTube, 55% in the case of Ebola on Twitter, and finally, studies conducted during the first phase of the COVID-19 pandemic found that between 0.2 and 29% of social media posts about COVID-19 could be classified as misinformation. Of course, the large variability observed in the proportion may have been due to differences in social media samples, methods, or the definition of misinformation. I have now finished with the 20 numbers that I wanted to share with you today. Now we know something about what the current data challenges and opportunities are to improve decision-making, not only for our politicians, but for the population in general. So now is the time to act, which brings me to the final slide and final part of this presentation. Next slide, please. Thank you. So what does WHO propose to address these challenges and take advantage of some of the present opportunities? Well, our first action is related to governance. First, we call countries to establish a high-level data coordination mechanism in charge of implementing a data governance framework composed of multi-stakeholder partners. This is not just about health. It is key to develop and implement a data governance framework to promote transparency and ensure use of common standards for data collection, reporting, and exchange. For example, we encourage establishing a centralized system to collect data in the correct format that can facilitate proper use and management, including integration, interoperability, and forecasting at the national and global level. In addition, we are convinced that only through the use of traditional and non-traditional data streams in combination with application of big data and data science methods will we be able to identify vulnerable populations and develop effective policy responses. The second action is related to investment. According to the Partnership in Statistics for Development in the 21st Century, also known as Paris 21, the international funding for data and statistics is only about half the level that it needs to be, as established in the Cape Town Global Action Plan for Sustainable Development Data. Hence, it is important to invest in strong data infrastructures and well-resourced statistical offices that can be useful for policymaking. And finally, we call to empower citizens, to provide them with the right skills to take decisions on their own health, and to help them understand their rights and the benefits and risks of sharing data, especially related to ethics, privacy, and security. We are convinced that only through governance, investment, and empowering users can we collectively achieve better data for better measurement, which could lead to better management and better individual and public health. And with this, I conclude my presentation. Thank you so much for your attention, and I look forward to the panel discussion that now follows. Thank you so much.
Thank you. Thank you very much, David. That was nothing but perfect. That's exactly the way to open this debate today. And if I may say so, a very original way to use data and indicators to make a very, very powerful case. You gave us a sense of the complexity, of the magnitude of the data gaps and the data quality. There are many questions that come up. I only ask you one as you save time, but I like our participants today with whom we'll get very involved. We have plenty of time. We'll have plenty of time for their involvement and debate with our panelists. There'll be issues I'm sure that you want to ask and bring, like the infodemics. I mean, the data, you put beautiful data. I mean, first the use of social media, 4 billion responses when you look at COVID, and then 29% of misinformation, make the numbers. And how do we empower those consumers, David? How we empower those users to use this data? There's been a lot of debate about the quality, the relevance of the social or with all these platforms. And indeed, I'm sure our participants will want to talk about infodemics, work that the GOG has been also leading, the work that the WHO, our Director General has been very much at the driver's seat about the excess of data and fake news for decision making. But the question I like to ask you, which puzzles me, as in an old one, David, is an old one. The timeliness, 2017, you said data, and the quality, 56%, and the relatively very small investment. Why? Once I was in a meeting with the Minister of Finance of Denmark. We were together in a platform, and he was laughing at me. I mean, he said, we have perfect data, we know everything about our citizens, we have appropriate investment, we have up-to-date daily data. Why does it take, if I die, God forbid it, from an accident, 3 or 4 years before I'm recorded as dead? And we paid an enormous price during the pandemic in decision-making. Why is this chronic thing? It doesn't make any sense. It's political will, it's lack of money, we want to hide the data. Are we totally incompetent in the public health sector? What is it, David?
Thank you so much, Joseph. That is a very good and pertinent question. I mean, this is my own views, but I mean, I think that we have dramatically failed during the pandemic just to have a common definition. I mean, so if you ask me for a specific problem related to data and what is the problem in general, putting aside the COVID-19 situation, is the lack of, I think that is a lack of interest, because everybody now is just talking about digitalization and nobody cares about anything else than just digitalization. But people doesn't understand, I mean, from my point of view, that when trying to digitalize data and information systems, digitizing a broken data process gives you a digitalized broken data process in return. And I think that this is the main challenge. We are missing the opportunity to improve our data systems, and we are just trying to digitalize broken data systems, which in return, they are giving us this situation that we are currently facing. So for me, it will be how we reprioritize this digitalization, that is the new wave, everything is about digitalization, and we look at what we would like to digitalize, and then everything will work properly. That will be my 2 cents about that.
Thank you. It keeps worrying me, this lack of will and interest. It puzzles me, and I hope now with the Recovery and Resilience Fund will be an opportunity to invest on those and make them relevant. Let me now introduce the next part of our session today, which is the 4 lighting talks, 4 minutes each. It's a really difficult task to do, particularly with people like me that tend to love to talk. So we're asking our colleagues here today to summarize their views in 4 minutes. I'll start with Cristina Pagel. She is Professor of Operational Research at the UCL. And she brings here, remember we talked about the process, the data to decision making, the whole continuum. And Cristina comes at the side of the research, and the research to advise, the research to provide support to decision making. Cristina, it's really difficult what you had to do, really. You had to use data which is sometimes of poor quality. On top of that, into operational research, you had to build all these models with huge amounts of uncertainties, and then you had to produce very timely and quality evidence to support decision, because the decisions were needed and immediately. So, Cristina, what is your perspective on the researcher and the advice to policymakers during the COVID? But the COVID, let me remind all of us, is just one of the shocks. We continue to see other shocks, and we continue having this situation of having relevant research, relevant evidence to decision making. Cristina, your 4 minutes, I didn't take any of your 4 minutes, start now.
Okay, so I'm actually going to talk about expert disagreeing and uncertainty. So there's definitely been a lot of uncertainty in COVID, and kind of 2 types of uncertainty. One is evidence about how COVID spread and makes people sick and what interventions work. And the other is on the basic nature of exponential growth. So with exponential growth, the nature of it is that you have to act while things are still uncertain. And so examples of that kind of uncertainty is how bad will it get right at the beginning of the pandemic? Will growth in young people spread to older people like last year when universities went back? Will region hotspots spread and new variants? All of that's kind of exponential uncertainty. And then you have uncertainty in evidence. So there's been uncertainty around masks and airborne spread, asymptomatic spread in children and schools, how much they contribute. And that, we really saw at the beginning, most people closed schools as a precaution, and then we managed to find evidence and work out how to keep schools open safely. Variants, transmissibility, immune evasion, a lot of uncertainty around that. And then even uncertainty at the beginning about how well the vaccines would work and against what outcomes. And experts have disagreed on pretty much all of that at different times. And with exponential growth, the result has been a tendency to wait for consensus, or to wait until we're sure. And that has again and again led to problems in many countries across the world, because by that time it's too late. For instance, there's no disagreement anymore about the variants. And unfortunately, what we see is there's no guarantee that the same disagreement won't happen next time. We saw the same thing happen with Delta that happened with Alpha. We see again and again growth spreading and people saying, oh, it's not that bad. It's not that bad. Disagreement on evidence has often tended to come to a consensus on clinical matters, on the best treatments for COVID in hospitals, on vaccine efficacy, and things like that. And I think it's because everyone understands the role of that kind of research and how you create evidence. Things where there's still not consensus is there's still a lot of debate around the spread in children and schools, around how effective masks are. And people have ended up with very entrenched positions that they started with maybe a year ago and haven't really shifted regardless of the evidence. And people kind of cherry pick the evidence to support their decisions on kind of all sides. And one of the big problems with that as well has been that evidence is parochial. So people are very connected into the evidence base in their own countries and tend to ignore it from other countries. So, consensus in one country is not the same as consensus in other countries. And we can see this playing out right now in Europe, for instance. Most countries still have some kind of mask mandates. Almost all countries in Europe have school mitigations in place. Most of them have been vaccinating teenagers, and that's in complete contrast to, say, the UK, where none of those things are happening. And here there's kind of, there's no consensus on masks, there's no consensus on this. I'm like, well, there is consensus, it's just not in this country. We see the same thing in America, especially between the northern and the southern states. We've seen the same thing with variants. We watched the spread of Alpha across the world in January. We watched the spread of Delta this summer. And in each country, somehow there was this idea that it wouldn't happen to them. And I remember talking to journalists and scientists in Europe, and they're saying, well, is Delta going to happen here? And I was like, well, why wouldn't it happen there? And what is the solution? Well, people disagree when things are uncertain. So I think policymakers have to be willing to act early to prevent worst case scenarios. We have to take every opportunity to collect robust evidence. And we have to learn from each other and learn from other countries and really believe in the evidence from other countries that aren't our own.
Thank you. That was impeccable, absolutely on time, and very, very rich, Christina. Christina, can I use the time can I follow on that? I mean, are you good? Are we good in the research world to communicate that uncertainty? Don't you think in a minute we'll talk about with our minister today, we've been blaming policymakers massively in this crisis. And yet again, have we been good in the research side on communicating that uncertainty? Haven't we sometimes we communicated uncertainty with lots of certainty, and then we blame the policymakers. Recently talking to a minister whose country I will forget now, I was saying I was lucky I never paid any attention on these models, on these forecasting models and all that evidence, because we'd have gone really badly because they were really, really limited. Are we fair enough as researchers to talk to our policymakers and show that we really didn't have a clue? It was a mess. I mean, the number of articles of whether it would be a meter, meter and a half, 2 meters, 3, 5 meters, it was confusing even for me, and I work in this field. Go ahead, Christina, please.
I mean, I think we're too good at communicating some uncertainty, and so often we're too saying, everything's uncertain, and then that people use that as an excuse not to act, when actually they have to act under uncertainty. But we're really bad at thinking about the uncertainty of what's going into our research. So particularly in the modeling side, it's what are your assumptions? How robust are they? And that side isn't often discussed. So for instance, a big disaster in the UK was care homes in the first wave, where the people doing the modeling had no idea how the care home sector worked at all. They didn't know that people were on minimum wage and couldn't afford to isolate. They didn't know that there was agency staff going between different care homes and spreading it that way. They didn't know that they didn't have PPE, like protective equipment. And so they completely underestimated the importance of that. And we ended up with, 30,000 people dying in care homes. So that kind of uncertainty, I don't think is communicated well. But I think most of all, people have to make decisions when things are uncertain. That's what we're bad at. We don't like doing it, especially when the decisions are unpopular, which they are in COVID.
Perfect, thank you. I think that has a lesson, if I may, Christina, in the sense that some of this modeling and some of this data has been done by pure epidemiologists, not enough psychologists, political scientists, and others understanding the nature of the health system, the nature of the behavior, and so on. But that was beautiful work. I'm convinced Claudia is monitoring the chat, that there'll be lots of points and questions in this area. Brilliant, thank you. Let me now move to our minister today, Mr. Daniels Pabluts, Minister of Health of Latvia. Daniels, if I may use your first name, the buck stops with you, and the blame is on you. So researchers tell you, some tell you the uncertainty well, sometimes they tell you worse, but ultimately you have to make those decisions under very, very complex situations, not only in terms of evidence uncertainty, but also enormous political pressures differences in values between member states that you cannot ignore in your own country, of course. So how do you bring all that together? It had to be a really tough, complex time. It is in normal times. It is in normal times. In COVID, even worse. Daniels, the 4 minutes are yours.
Thank you, Joseph. Well, thank you very much for inviting me as a politician, which I am first and foremost. So my remarks might appear somewhat down to earth to some of you, but so I'm going to talk more about how things are rather than how they should be. But let me share some thoughts specifically on strategic use of data to promote differences of opinion, which is a fact of life. Now, the problem is usually that we are dealing not so much with false statements per se, rather partial, simplified, out of context, outdated information. All of this to make it more appealing, convincing to the general population, promising easier solutions to complex issues and providing perhaps a temporary sense of cognitive comfort. Now, we are a small country. I'm from Latvia, so we mostly rely on research and data and findings from other countries. So do other parties. Everybody has that availability. So it increases greatly the variety of conflicting data and approaches. So the information pool to be used and abused is indeed global. So, and it's not only cherry picking of scientific facts, which Christina already alluded to. More often we hear contrasting bits of pieces of policy approaches also used by other countries and their epidemiological realities. So, in other words, our problem is not so much outright lies or false data or the lack of data, but weaponizing selected partial truths, misuse of data. So a couple of strategies that we observe. First, enough with that. The situation has changed. This is no longer serious. With Delta and vaccinations, we frequently hear this research findings that, this fall, the situation is different, data is different, it should be treated different. And by the way, COVID restrictions are no longer relevant. And then we hear about much easier restrictions elsewhere, and why don't we do the same? So it completely misses the full picture, the context. We have relatively low vaccination rate, as many other Eastern European states. We see high infection, hospitalization, mortality rates similarly to our peers. Unfortunately, to counter these arguments, we can't just provide more data. The population treats pandemics as the new normal, and they're tired of data. And our population, as well as consequently political class, really do not pay attention to the data the same way. They've gone largely COVID deaf. And one bit of data that politicians pay attention to is opinion polls, and they should. Now, well, easy to grasp bold graphs help, but we need to find ways to win hearts and minds by providing real life stories and evidence to get through. On the other hand, obviously, we'll get blamed for scaremongering. That's our reality. Now, second strategy. Well, this is illogical. That's the wrong approach. So what does that really mean? We observe policies of other countries, we follow their work and apply some of that, but so do other parties. So they question our approach and credibility based on bits of pieces of other countries' experiences. So it completely ignores the cultural, economic, social realities of other countries. Now, what we do is Gormley's classical policy salience and complexity quadrant helps. First, if we can quickly solve the most salient issues, so we move other decisions out of the public arena so they can be discussed more professionally with relevant degree of complexity and detail. The second is by increasing the complexity, reconstructing the full context around these problems so that we can have more nuanced context. But obviously this might not be available due to the already mentioned lack of attention. Now, last but not least, we see conflicting arguments used daily to influence decisions at the professional level, frequently juxtaposing experts and politicians. Now, we try to use as much as we can transparent, rational, honest communication about decision-making. Now, using scientific experts themselves, consistently sticking to their advice, constantly referencing to them and promoting them, giving them voice instead of just retelling their suggestions like I would. So certainly not all political decisions follow expert advice. So they can criticize decision makers and they can be justified for doing so. On the other hand, scientific understanding evolves, uncertainty exists, and we need to admit mistakes, outdated policies promoted by experts previously. So this triggers inevitable criticism towards experts themselves from people and pundits. A poignant case in point is ongoing, raging discussion around third doses. I remember, I think it was a quote attributed to Henry Kissinger, apologies, I've got that wrong, that there's nothing more alien to a politician's mode of operation than the mode of operation of a technocrat, an expert. And it's certainly true in the COVID context. Don't get me wrong, I respect the opinion of scientific experts, I stick to their advice, I believe that increases credibility in the longer term, and this is my stance. But even the best data will not convince people who lost all trust in the government and experts. It will help, however, maintain support of those that still put their faith in critical thinking, evidence-based policy, and sound judgment. And I'd like to think that these people are my voters at any rate, so we're on the same side. Thank you.
Absolutely perfect, Daniels. You brought us to reality here, a harsh landing to the reality of decision-making and the limitations and of evidence in policy practice. And indeed, actually, I would agree with you that the opinion polls are an important source of evidence, a licit and valid source of evidence. At the end of the day, your power comes from the people, and you have to reflect their views. And if these opinion polls reflect realities, that's what you're meant to do as well. But let me ask you just a question before moving to the next one, which you alluded beautifully well, Daniels. In our research we're publishing now at Resilience, Resilient Systems, one of the key factors was the quality of the leaders, i.e. you and your Prime Minister. And as part of that quality of the leaders is this ability to communicate uncertainty, to communicate errors, to accept errors. That has apparently developed into, depending on the societies, but mostly brought trust and brought compliance from this population to follow then the advice. But it's terribly difficult, if not impossibly, politically to accept errors and accept uncertainty. What would be your reflections on that, Daniels?
I completely agree. But you see, there is also the importance of understanding cultural context here. There are some countries, and perhaps in a European context, more to the west, perhaps more to the north, it would probably be accepted that admitting mistakes is a sign of strength by a politician, by an expert, whoever. More to the east, however, this might be perceived differently. Admitting mistakes might be seen as weakness. This is a different culture perception, different culture type. And my country, as a case in point, is sitting on a threshold, sort of a, like a membrane between these two cultural spaces. So that makes things much more difficult. Now, admitting mistakes is a daily phenomena for us. I mean, we make mistakes, we make the best of the data that we have, we make the best of the political capital that we have at a given time. On the other hand, it's not an all-purpose solution, unfortunately. And we've seen this happening, that when experts make mistakes, we may apologize, we may make amends, and yet people will fall back to those mistakes, including politicians like, not myself specifically, but some of my colleagues in the cabinet, would keep going back to those mistakes experts made in, say, selecting vaccination portfolio, what the advice was. You might recall, this was really a very difficult, still is a difficult conversation in our country. There was scientific advice, scientific view that, we should put our bets with AstraZeneca, and, Pfizer is complex to administer, et cetera, let's, it ended how it ended. And basically, one cannot blame the expert because the expert's not making a decision. The risk-based decision-making is a politician's law. It's the manager's thinking. So, but maintaining that balance of what is the importance of data and expert opinion, and where the political responsibility for making managerial decisions that entails risks of lives and etc. This is not an easy conversation to make, and no apology is sufficient when the outcomes are suboptimal. Let me put it that way.
That's perfect. Thank you very much for these reflections. That will trigger a lot of debate and questions in a minute. Let me now move to Melanie Carr, Head of Stakeholders and Communication Division at the EMA, the European Medicines Agency. Melanie, you're in a hot seat as well. You are in a hot seat. The amount of pressures with the new treatments there, with the need to have those into the treatment, into the member states, being approved, being used, had to be a communication nightmare for you to explain, to be transparent. And I suppose you had to face with this thing about how much evidence is enough to then authorize vis-a-vis the trade-offs of timeliness and the need to have these treatments out there. How did you deal with all that, Melanie? Your 4 minutes.
Yeah, thank you, Joseph. Good morning to all, and thank you for this opportunity to join this interesting panel discussion today. And indeed, maybe nightmare, very challenging, I would say, the past 18 months, 2 years has been, and certainly from a communication perspective, we've been on a very steep learning curve. And David provided some very nice figures to illustrate the extent of misinformation circulating. At EMA, as the responsible authority for evaluating new vaccines for the European Union, we consider we play an important role in fighting that wave of misinformation by being a reputable source of information for EU citizens. So I'd like to say a few words about how we're tackling it, how we're tackling communication at EMA. And one important element that is key to reinforcing trust in regulatory decisions is to be as open as possible. And we put in place extraordinary measures really to enhance the level of transparency for COVID-19 medicines. So we're publishing information throughout the medicine's life cycle on those medicines and vaccines under development, once they're under evaluation by our committees, and also once they're authorized and rolled out in vaccination campaigns. Another important element as a scientific decision maker is weighing up evidence, explaining the reasoning to make our communication meaningful. So our scientific committees evaluate data and they take informed decisions on the quality, the safety and the efficacy of vaccines and other medicines to form the basis for the authorization. Now we communicate those outcomes of our assessment and we provide different levels of information for the public and for stakeholders. So it can be a public friendly question and answer, the summarized product information, the more detailed assessment report, which explains why we've taken the decision on authorization and gives information about the assessment. And also we publish the underlying clinical data for COVID-19 medicines. So those academics, those experts who want to delve in and undertake a more detailed scientific review can do so. This doesn't stop at the stage of authorization. Post-authorization, we continue to gather data, monitor vaccines closely through safety reporting, post-authorization studies, and experience gleaned in the real-world setting. And we have an early notification system in place to communicate rapidly with member states. We publish monthly safety updates for all vaccines, and we issue public health communications. Evidence takes time. Now, focusing down on the data to communicate what really matters is challenging, particularly as safety signals arise from post-authorization surveillance. Now, in our experience, it's been a steep learning curve. It's important to communicate rapidly what is known. And as Christine said, as also the uncertainties, so explaining the further steps that are being taken to gather data and investigate, and also to provide regular updates on the review being conducted by our committees. It can be daily and then move into weekly. We do this through public health communications and also through press briefings. And then often a more detailed review on vaccination data and epidemiological data will follow, for example, to contextualize the risk. That can take longer, so further communication will often follow. And although the level of interest may have waned by then, it's very important to communicate the formal conclusions, and we do that, and we also publish the assessment reports. So in summary, we consider access to data is key to reinforcing trust in decisions, and particularly in understanding the rationale underpinning important decisions on vaccines. It's not just about transparency, however. We don't just want to publish information, we want to communicate better, add context to the data and explain the science in plain language, And finally, engagement remains crucial. So actively listening to questions, to any concerns, so we can hopefully address them, and involving stakeholders and members of the public in our activities, so we can take on board their feedback and hopefully continue to improve. I'll leave it there. Thank you.
That's very, very, very helpful. Thank you very much indeed, Melanie. Congrats to EMA for the work you've been doing in such difficult times, and congrats because you're going to be further strengthened, and rightly so, I may say so, through the European Health Union initiative. If we had time, I would like to hear about that from you as well. Melanie, I love what you said, but still there's the art and science, isn't it? And the art element is when the data is limited, and you face very limited data, it's okay to share it with researchers, but what about the public? And we'll talk about the public in a minute. At some point, you said it beautifully in your quote, you know, evidence takes time, and by when you have it, the story has moved on, and here Daniels needs to make decisions, and so are the researchers to communicate. How did you deal with that conundrum? Say, is it enough to put it out there? We'll be able to explain it. How will explain that uncertainty? Because the media doesn't understand uncertainty, hates uncertainty, and will take whatever part of the story they love. Could you give us a bit of nuance, a bit how you handle this complexity in the day-to-day running communication at EMA?
Yeah, I mean, one thing, thank you, Joseph. I mean, and it's a very good question. One thing to explain is when we're looking at medicines more generally, I mean, we're used to dealing with uncertainty. So, you know, when you're looking at the benefits and the risks, which, and looking through the data that's been generated in clinical trials to take decisions on authorization, it's finding this balance. And we've always been working to explain what you know and where the uncertainties are and what you don't know and what additional information is coming. I think the challenge in the pandemic has been the demand for data, but also the urgency at which people need to get their hands on that. Not only the public, but also the decision makers. And here, I mean, our approach has been to communicate as quickly as possible, to be open and transparent, as we said, to say what we know, but also to say what we don't know, and to explain how that can be put into context and what that means in terms of the benefit risk balance, and why we feel that we have enough to make the recommendations on the use of the vaccine that we've made. So I think it's trying to explain in simple terms that there's going to always be some level of uncertainty around medicines and vaccines, and it is about the balance.
Perfect. Thank you very much. Thank you very much indeed. Last but not least, Marijn de Bruin, Professor of Behavioral Medicine and Health Psychology at Radboud University and Chief Scientist on the Corona Behavioral Unit at IBM, National Public Health Institute. Marijn, I'm not surprised there's no trust out there in the population. With all this complexity on data, this contradictory advice, mask, no mask, and the Netherlands is a good example of having gone their own way. Can you give us a sense of why we lost that trust? I think we do understand that why we lost that trust, but how do we regain that trust again? How we communicate better? How do we understand the perceptions, the cognitive biases, the various ways that our population understands all that? And how do we regain that trust and hopefully compliance with what we believe is the best evidence available? Marijn, the 4 minutes are yours.
Yes, thank you very much. I often start my talks with saying that the problem is the virus, but our behavior is to a very large extent, at least, part of the solution, like social distancing, testing and isolating, and then vaccine uptake. Many countries follow epidemiological and virological advice, and they've got really amazing data, at least in the Netherlands. And I have to admit, as a behavioral scientist, I'm actually quite jealous on the quality and the amount of the data that they have available. The recommendations that are based on that are often behavioral. So they're focused on reducing the number of contacts and reducing the riskiness of our social contacts. And because it's behavior is so critical to the success of those recommendations. We also think it's very important to monitor behavior and its determinants, but also potential negative impacts over time. So, for example, our social well-being, mental well-being, but also our trust in policies, as you say. So in the Netherlands, I'm leading the behavioral unit, which we actually started in March 2020. So behavioral science wasn't an integral part of the pandemic response initially. So the Public Health Institute here helped us set it up. And we had to develop the research, scientific advisory boards, get funding, get a team together. And we're now a trusted party, but we're not entirely fully integrated yet in the structure. Our research focuses on adherence, following behavior, but also the behavioral determinants. They can be contextual, they can be social, they can be in the person itself, and trust in policies, support for particular measures, and also well-being. And we put all this information on the website of the Public Health Institute, but the government here also has a dashboard that also includes part of the data that we're collecting on adherence to the measures and support for the measures. And both media and citizens are making a lot of use of those data sources. We also use these data to advise on press conferences, on public health campaigns, and we have a procedure for reflecting on upcoming policies and saying, well, we think this in relation to policy support or well-being or adherence, we anticipate those opportunities or challenges. And finally, of course, like in many countries, there's a lot of media attention for the topic. So together with the 25 professors that are advising our behavioral unit, there's many hundreds of times that these data have been part of mainstream media articles and TV programs. So I think as a behavioral scientist, it's great that people can follow sort of in real time what's going on. But I also think this can be more comprehensive to capture more of the complexity that people are experiencing. So there's really a trade-off between fighting the virus and well-being, for example, and adherence and policy support. And our data shows that procedural justice, we think that's a very important factor in relation to public trust. It relates to, given the complexity, what information was used to arrive at particular decisions, how did the government weigh the pros and cons, and how well are those decisions explained? And we see that people are actually quite critical on that part. So we think that is very important for policy support and trust. And I think that behavioral science could contribute more to this and to other topics. And how that is by sort of fully integrating behavioral science in the pandemic response, but also for behavioral science to be better organized. I think behavioral science needs better data. We often have surveys, we need more objective data, and we need to be able to translate that in a very actionable format that decision makers can use for making their policies.
Great time, Marijn. This is incredible.
Yeah,
so
I was amazed as well.
Exactly. I couldn't believe it. It's been 0 seconds. You said your last syllable, as it were. Marijn, we all totally agree with you. Actually, we should have had much more behavioral science during the crisis, but also in all, many, if not all, public health decisions and policymakers' decisions. And I love this idea of procedural transparency to create trust, to understand, although, of course, the world should be full of Dutch as well if we are going to use that effectively. The Dutch are particularly good at transparency and debate and openness, but that's what we want of our societies in general. Very, very briefly, because I've been taking too much of your time already, colleagues. Marijn, one question. Do you do enough behavioral science on our policymakers and our researchers as well? Our advisors? They do have their values, as I said at the beginning. Do we understand them well as well? The same way that the population has all these various biases and views and values and so on. Don't you think you should do more research on the policy decision making and the behavioral decision makers and what affects them, so we understand them better and we support them better?
Yeah, I think so, but it's probably not my role at the Public Health Institute to do so. I think there's definitely lots of people who are going to study the decision-making process that has been taking place in many countries and how different types of data and sources have been used to make particular decisions. But to study the Ministry of Health that is basically funding our public health institutes, I think it's more trustworthy also, and to have the independent parties look at that process and do the evaluation.
Maybe not you, but in general, the research community, I think we need to understand, but in a way that then we can support them better. Yeah. Claudia, back to the chat box and your leadership here. I don't think you'll hire me again, or invite me as a moderator, because again, I'm 10 minutes behind, but we still got full 30 minutes to hear our colleagues and wrap up. Claudia, back to you.
Thank you all for your inputs, and also for Josep for your kind words. I think there was the FAQ section. There are quite some questions, and thankfully some of you have answered already. I think one important point was discussed between Petronil and Daniels. Petronil is from our partner institute Sciensano in Belgium, who is leading the PHIRI project I mentioned. And it's about the trust. How can we all win trust from our citizens? I think in the beginning we made some, when I saw the data of David also yesterday in the presentation, when you shared it with me, I was so impressed by the sheer amount of information available. We as researchers and experts have always the feeling we have to give the people more information, and then they will understand or will trust us. But isn't it on the contrary? Josep, you said it so like in a sideline. Oh, there were so much different information. I couldn't even follow myself, and I'm fully into that. And I think I had the same feeling very often. My mom was asking me, what's the new regulation for this and that? And she asked me, why did they change it? And I could tell her perhaps this was changed in Austria, but I could also not understand why it was changed, to be honest. So perhaps too much information is also bad. And this winning of trust is also a very good question. And I think Daniel, you wrote it in the chat, there is no single answer, but how can we do it? And I think countries who are doing well in the pandemic crisis now, like Portugal, what did they do? They had really a national solidarity movement. People were proud that they got a vaccine shot. The president congratulated those cities and villages who had the highest impact, the highest vaccination rate. And I miss that in a lot of countries. In my role as international affairs, I see that it's quite a different approach in a lot of countries. And what I miss in some is really this, let's say, national solidarity. Perhaps this is an old-fashioned term, but perhaps we need it this time again, So if we can hear some views on that, I would be pleased.
Thank you very much. We heard indeed about trust from all of you. We talk about procedural, we talk about transparency, we talk about immediacy, timeliness, uncertainty, all of them to build that trust. But can we pursue that further? Because it's been really central
for
to
Christina,
the
perhaps,
successes and failures. Exactly. Christina, would you like to go ahead with that one?
Yeah, because I just think this is such an interesting thing to think about. So in the UK, we had actually a lot of trust in the beginning, and people were really much more adherent to things like lockdown and masks, and people were expecting that, you'll never get British people to wear masks. It was mandated, and over 90% of people started wearing them every trip to the shops within a week. It does happen, and people did feel that solidarity. We have clapping for the health service and everything. And then gradually the shift has been to individual responsibility. And it's up to you, and you have to do things for yourself. And all of that sense of doing things for other people has kind of been lost here. So mask wearing is one really obvious example. But even like with vaccination, the UK was very, and justifiably proud of itself for being very quick with vaccination this year, but has no idea that now several other countries are far higher, and we've kind of very complacent about it. There's, since March, we've seen far less uptake in more deprived communities and among ethnic minorities. So for Black people living in Britain, only 50% have been fully vaccinated compared to 80% of white people. And it's something like 90% of highest income compared to 70% of lowest income. So, there's these really big gaps, and we're just not doing anything about it. And where does the burden of COVID fall? It falls on the deprived communities. And so we're breaking social solidarity in a way by doing that. And it's really obvious how the impacts of COVID over the last year and the impacts of lockdown and the impacts of losing jobs in the economy has always fallen on not everybody. And because we've lost that sense of solidarity, I think now it's like everyone for themselves. And it's really sad to see. And you're kind of seeing it play out in a more extreme way out in the US right now, where you're actually getting really horrible language, even from leaders, about people who are unvaccinated and calling them selfish and awful. And you're just like, I can't see that that's helpful, that you're creating these two tribes. So again, those are my thoughts.
Thank you. Colleagues, anyone else wants to come on board on this issue? Yes? Melanie, I think you were raising your hand, your real hand.
My real hand. Yeah, I mean, it's a very interesting discussion. And I mean, my reflection would be also that, you know, one of the wonderful things about the European Union is we're such a melting pot of different cultures. And I think one of the difficulties here in trying to understand how success in one area can be taken up and reflected in another. And it's not easy because it's not a one-size-fits-all approach. And so I think a lot more has to be done in this engagement, in understanding where there are reservations, where there are concerns, because they may be very different. And you know, we may think that we can address them, but we're not answering the right questions. So I do think that there's much more to be done in reaching out across different stakeholder groups, across different populations. And really, from the communication perspective, there's still a lot more to be done there. Over.
Thank you. Daniels, may I push you on something? Sorry, and then I'll bring Marijn quickly. Daniels, can I push you on one thing? What we observed as well is that the weaponization by the political parties themselves, by the different parts of government, sometimes against each other, as you, I think, briefly hinted, by the contradictory advice from different parts of the government, by in some countries highly decentralized, different views of the regions and central level. Don't you think there's an element as well, it's beyond the research, it's an element of responsibility and accountability to our policymakers in having lost that trust?
Well, clearly everything that we have observed during this pandemic, which is a crisis of extreme proportions, goes well beyond pandemic itself. I mean, it's eye-opening, it's sobering about human nature, after all, about nature of societies, about, you know, all that socio-psychological phenomena, identity creation, identity groups, group relations, which we deal with by the means of politics. So it's not surprising that we see these different suboptimal phenomena in the pandemic context. So we become our own enemies. And I guess there's no escape from what we are or where we are in a given society, in what context we are. It's very interesting to try and make sense of vaccination rates, for example. You may try and explain the levels of vaccination in EU, for example, by who had it real bad last winter. Works to some degree, but not really. Explains France, Spain, does not explain Czech Republic. If you look at, say, the post-communist past, works quite well. From the bottom 10, 11 countries, pretty much all countries are Eastern European countries in terms of vaccination rates. So there's really no escape from human nature, history, specific context, but it's tempting to try and address this as solidarity issue, but it's far too oversimplified for my taste. Certainly not for understanding local specific situation.
History of mistrusting the state. Marijn, you're going to add very briefly, because I'm sure Claudia has many other questions and we'll give you plenty of speaking time as well, Marijn. You want to add the comment in there?
I think with respect to the solidarity, I think when more of the negative impacts of the measures became obvious, like schools closure, learning delays, mental well-being, closure of pubs and restaurants, that's when there started to be different beliefs about what solidarity actually means, solidarity with whom. And so I think there are still groups of people who have the idea that they're being solidar. How do you say that? That there is solidarity within them, but they've just taken a different turn at some point, weighing the pros and cons of the measures differently.
Marijn, we lost you a tiny bit, but we got the main gist of what you're saying. Check your microphone, please. Clearly, solidarity, not within the country, but across countries and towards the south. The topic has been very nicely addressed in Gesundheit, and that solidarity is lacking. Claudia, back to you.
Thank you. What we are also wondering is, and we saw a bit in the chat, is the patients, were they good involved from the very beginning? You know, did we listen to the target group? You know, who in the end is the one we would address, we want to convince, we want to show. For instance, there's a lot of measures communicated, but usually there was no communication in a lot of countries on why there was a change. You know what I mean? So the reasons. What do you think? Would it help if we could explain that more? Would we reach some population groups which are now skeptical by telling them why there was some changes? Or is it too much and would just add to the tons of information in an unnecessary way?
Good point. How we reach there? Although I'm not sure, Claudia, we want to tell the patients how the policymakers and sometimes even researchers, advisors reach at the decisions. How far you want to be transparent? Please, someone raised the physical hand. I think it was Melanie.
And Daniel's then, yes.
And Daniel's, perfect. Melanie?
Yeah, no, certainly listening to different stakeholder groups is very important. And I mean, at the agency, we have, you know, a standing working party of patient consumer groups, but also healthcare professionals. And what we found in the pandemic, and I said it's been a very steep learning curve for EMA, is that there was a need to go beyond this. So we started to organize public stakeholder meetings, and we've organized 3 so far, where it was a run through what the latest information we have on vaccines, but really an opportunity to hear what the questions are, so what the understanding is. And we've also been working more to use a test material, because it's right what you say, Claudia. It's not always about putting more information out. Sometimes more isn't better. It's trying to explain it better, so to communicate better. So I think this user testing with groups because what we think might be a good visualization to explain something isn't actually, because we know a lot about the process. So it's about getting targeted messages right. Over.
Thank you, Daniels.
Yes, this is tricky. As somebody who's been, you know, multiplying all those many messages about all things related to pandemic from experts and everybody else, there's always this asymmetry between supply and demand of communication. When you're already sick of a message you're trying to deliver, they only begin to hear. And even then you're not sure what it is that they are really hearing and perceiving and turning into action. Now, of course, it's easy to always want better and more communication, more precise emphasis on priorities. But sometimes we only learn what those right priorities were with hindsight, post fact. So that makes it difficult. Plus, I think that the nature of public opinion, the nature of human perception is not necessarily a linear or logical task. Now, who could explain to me in rational terms, why would one type of vaccine by now be total, you know, off the table, while the other of the same technology, at least in my country, is sought after, queued for, and actually part of the solution to the problem? Makes no sense. I mean, the way the narratives have developed, and experts actually played part, I'm sorry, in the spring. We remember the countries that were more skeptical, less skeptical, back and forth. There was a lot going on, which would need to be looked at some point. So this is not a straightforward, non-linear, complex process. Thank you.
I think,
Daniels, I think, sorry, yeah, no, I'm saying that this is your responsibility, if I may provoke you and the colleagues here on the table, including the WHO and Emma and the others, to actually provide the kind of being able to target those groups. I think we should talk about infodemics and the work that the WHO is doing, that they're trying to monitor the views of the public, the misunderstandings, and we need to target those messages to these groups in Facebook and in other social media to be able to do that, because it makes no sense, but it happens. It happens that some vaccine is perceived as better than other. So in some ways, it is back to the public sector, the researchers here, the communicators here, that we are not good enough, I think. Sorry, Claudia, you were saying?
I know that Christina also wanted to add something here, and it was very good that you also passed over to David on how we can react. So Christina, please.
Yeah, just on the communication thing, and you know what Daniel's was saying about people getting, you have to be bored of the message before people listen. And what's quite striking here is how people have, at the beginning of the pandemic, there was so much appetite for knowing about it, that the messages from a year ago have stuck, even as the evidence has changed. So for instance, the symptoms of COVID in the age of vaccination and Delta have changed. They're much more like a cold than they are of the classic temperature and cough. But people don't know that. And so they're not getting tested, or the airborne nature of spread. So I still see people walking around with plastic face shields, which just don't do anything. And you still see a lot of performative, well, it's now performative, but people being obsessed with disinfecting every surface in a completely unventilated room. And you're seeing that those messages actually of how it spreads have not been updated. And I don't know whether part of it is that you can see people cleaning, but you can't see air. But it means that actually we're missing a trick in trying to prevent cases, because we don't, people still aren't really understanding what is important in preventing infection and things like that. And I don't know what the answer to that is, but I definitely can see that some of the really basic public health communication has not been affected over the last 6 months or so.
Thank you. David, we want to come to you because you've been working. Also, Claudia may want to respond to this one as well, because you are an expert today as well in this area. On the infodemics, what are we doing in the infodemics to address these misconceptions, these misunderstandings, and this, Christina, old habits die hard, isn't it? So how we change those habits already? David.
Well, so yeah, I don't know. We are trying to address and to cluster our focus on 4 specific activities. So first, we need to continue listening to the community, to the concerns and questions, and continue learning. So monitoring social media is not easy at all. So we are listening to billions of messages about what is happening and how we can understand and how to address these concerns. Also, we need to promote understanding of the risk and the health expert advice to be sure that we can capture the best available evidence to transmit that in a proper way. Also, we need to continue building resilience to misinformation, and that is key for us. And finally, the most important is continue engaging and empowering communities to take positive action. So it's not an easy task. There is a lot of still to do in this field, and we are still learning. So we think that, for example, in these cases, data science is playing a key role, trying to capture all the available information that is around and trying to cluster this information that we can capture and capture in direct messages that can get to the population, and then with the right message. But this is not easy at all. And we are still learning what is happening. So a lot of to do, but we are excited that we had the opportunity to continue growing in this area of work and helping the community and the politicians. Thank you.
Yeah.
Thank you. Back to you, Claudia.
Yeah, Joseph, and thanks for all these inputs. But I personally think that we, should not generate too much information additionally, unless there's a new variant or whatever, but just repeat and repeat and repeat what we have done. And perhaps when we disseminate it, it should be more on a granular level. We have to address a homeless person differently than we have to address a 15-year-old person with a migrant background. And a lot of countries who were doing well, like Ireland or Norway, they had a lot of information materials in different languages. I think Ireland had around 20 languages Who else did that? You know what I mean? So there are some best practices around. We need just to follow up on them, you know, instead of reinventing everything. I just calculated 1 million experts around the world approximately are looking into Corona every day, you know what I mean? So I think there's plenty of brains around and plenty of good ideas. It's just on us knowledge brokers to allocate that and streamline it and bring it to the attention of the decision makers. I think that's in the end, in a nutshell, our job. Yeah, and repetition. I know it's bothering you perhaps, but I think it's the only key to success.
How do you feel about that?
All right, I think one word before we conclude.
Is
yes.
mic working again?
Yeah.
Yeah, excellent. Okay. Yeah, so I think one of the challenges, at least for us here, is that we generate those insights and understanding on behaviors and misconceptions, but then we are not the party that is responsible for the public health communication campaigns. So it goes through different layers and different parts of the organization. And I wonder if anybody has an example of a country where the behavioral science insights and the misconceptions, where there's a system that functions really well in translating that in campaigns that are tailored to target groups, different media, different language, different formulations, different timing. Is there an example to your knowledge where that is sort of an integrated, fluent system?
We thought about the Netherlands, I think. The Netherlands is such a system. You know, you have one of the sole foresight units, can I say so? You know, you did the big foresighting report with Henk Hildebrink last year. This was, I think, a challenge also in a lot of countries. We didn't have this type of units at ministries or at public health departments. In ours, we don't have such a sort of department yet. Huh? But still, we have started a process on this, and this is perhaps one of the lessons we learned for the future.
But so my point is that still here, it is difficult to say, well, this is the evidence that comes from the research, and then to actually see it being translated in a campaign within a month, for example, and reaching all the different people that we're recommending. That's still very difficult to get into. Yeah.
And that's the way, actually, I think we need to wrap up and bring in our director of GOG, Herbie Kosterman. But before we do that, can I ask you, literally in 2 words, to respond to this question as a way to wrap up our panel before to conclude? We have now this famous 650 billion of the Recovery and Resilience Fund. We've been looking at the programs of investment of different member states, and a fair amount in some of those will go to health. If you had, say, 500 million of that for your country, for this area, where you would put, in which basket would you put those eggs? Don't tell me digital health, please, because we know that many countries are doing that, and it is the case, but it's not enough. Having lots of IT and so on is important, is fundamental. David has presented that beautifully, but clearly we learned today, we know it's not enough. Can I ask around, please, in the same order perhaps that we had the presentations on one sentence, where would you put this 500 million in your country? It's a lot of money, I know, to really ensure that this data to decision making works much better and improves, obviously, the health of our populations. May I start with Christina?
Wow. Well, I guess, how about a slightly different view, right? Which is that I think we're really good at measuring things, particularly measuring things like inequalities, and much less good at acting on them. And until we actually prepare to do something about the numbers, that's what we have to do. And we know how to do it. We know how
money
to
tackle. Money on action equities.
Yeah,
I will ask you to do so because we
it.
need to conclude. So I'll ask you very short. I know it's not an easy question. So more action on inequalities rather than talking about them and measuring them, because we actually do know sometimes quite well who are the vulnerable populations. Daniel, you will have that money, or you have that money probably in Latvia. I'm not going to ask you where you are going to put it, but where would you put it in a virtual world?
Joseph, I will disappoint you. I was taught in leadership to distinguish between technical challenges and adaptive challenges. Technical are the ones that you can throw money at and create yet another data panel and, you know, whatever tool. And that we have money for that. Adaptive challenges are the ones that require a change in attitudes, in skills, etc. So if I had the money and time, I would throw all of it at, you know, educating people in critical thinking, in use of data, in, you know, basically resilience. But we don't have the time.
Perfect, perfect. We don't have time to say anything, but may I say I would agree with you. Melanie?
Yeah, perhaps not surprisingly, my focus would be on the vaccines. So it would be to work more on increasing supply and uptake, not only across the EU, but globally.
Perfect, thank you. Marijn, and then David, I'll bring you on board. Marijn?
Yeah, the selfish option would be to have a work on an infrastructure for behavioral science with much more collaboration and objective monitoring of data. And the non-selfish options would be to use it for vaccines in low-income settings.
Brilliant, thank you. David, you already mentioned with your recommendations. Can you take one, please, where you would put your $500 million?
If I were a minister, I will put everything on governance and to be sure that I am prepared for what is coming next.
Perfect. Actually, the minister went into that direction, governance and education. Claudia, back to you now to introduce also your director and your last comments.
Thank you, Josip, and thanks for moderating this so well. We only have a couple of minutes left, so I really hand over to our executive director, Herwig Ostermann. He's also board member of Gesundheit. So, Herwig, please.
Well, Claudia, thank you. Thank you, and thanks to all the speakers and Josip for this excellent session. And obviously, I only have a couple of minutes left, so I will try to put it quite short. But one notion I would like to share with you was the last Gesundheit meeting we had on site, which was in 2019, and the conference theme at this time was a healthy dose of disruption. Well, we had some disruption ever since, but we also had, or what we also could observe was the fact that health policy was essentially or suddenly in the heart of political decision making. And this gave us loads of attraction, not only from the health policy scene, but we are at the center or at the heart, so to say, of the current governmental agenda throughout the whole of Europe. And this is a result of the pandemic, and it is some kind of opportunity. What I have learned from this 88 minutes by now is actually that we have to be transparent, and we have to be transparent on data, and we have to share the data regardless of, so to say, the area the data is covering. Once data is not shared, actually it is, you know, a source of misuse. It is a source that actually makes people think that something has to be hidden. So we have to be brutally transparent on data. The second thing, we have to be transparent also on uncertainty. And I'm not quite sure whether this is an easy task. In fact, also a treatment between a physician and a patient most of the time has some uncertainty in it. And to communicate this is in particular difficult if we cannot actually assume that there is mutual trust. And the pandemic actually showed us that trust between government on the one hand, also science and academia, and the population on the other has somehow diminished over the time. And the third thing to be transparent on, we have to be transparent on our own misjudgments and our own errors. Everybody was wrong with regard to their forecasts. Everybody was wrong with regard to their perceptions on how the pandemic would evolve. And we have to be transparent in this respect as well. Maybe this is one strategy to build trust with the population. And an ultimate closing remark, I think we also have to be more European-minded again, and we have to talk to each other. In our member states and our national pandemic management boards, we have a tendency not to talk to our neighboring countries. And we always think then that it is better, or the pandemic management is better at some other place. And as Daniels put it, it's context specific, and we have to learn from different contexts, and it's a complex issue. And we can only learn actually if we foster again this mutual conversation across borders in a European setting. And this is why the European Health Forum Gastein is so important. And this is why I thank you all for attending this session. Thank you.
Thank you very much. That was a brilliant conclusion. Thank you.